Hello everyone, my name's Viraj Barambi and I'm going to be talking to you today about the neurological history and examination. So let's get started. Today's learning objectives are firstly how to take a good neurological history and also importantly how the neurological history differs slightly from other forms of history taking in medicine. Then we'll move on to talk briefly about the differences between acute, subacute and chronic disorders and how your history can help diagnose these. And then to finish, we'll go rather quickly through how to examine cranial nerves and peripheral nerves. So to get started, how do you take a good neurology history? Well, it's not too different to other histories in that you start with open questions. So starting with a generally open statement that can be answered by the patient however they wish. Something like, tell me about the problem, or tell me more about that. And then after they've told you their narrative of how things have gone, then you can move on to your own style of closed questions. Things they may not have mentioned, things like, did you have pain? Or how long did it last? When you want to, clarify the details of specific things. And where I think the detail is really important in neurology is all about timeline. So you need to be a little bit more specific about when something started, how it progressed, and we'll talk a little bit more about that on the next slide. This is going to be difficult from early on in your careers, but as you get better, you'll be able to start working out the diagnosis straight away. So once they start telling you their open narrative, you can start asking specific closed questions to either prove or disprove your hypothesis. So if someone says, oh, I had sudden onset left-sided weakness, doctor, your hypothesis might be, oh, I think they're having a stroke. And you can ask specific questions in which way to prove or disprove that and move on to the next diagnosis. But I think that at this stage might be a little bit difficult. Importantly, I think in all history taking, it's useful to know how this illness is affecting the patient's life or their work. This is mainly to kind of indicate to the patient that you care, that they will also understand that you're a better doctor for knowing how that impacts them. Sometimes patients themselves can be either confused or unconscious, and it's obviously very difficult to get a history in that circumstance, and often with permission it's useful, almost always really in neurology, to ask a relative or a friend whether they agree with the history that's being given. And you'll be surprised how often that's not the case and how often you can get very useful information from other people's accounts of what's happened to a person. So to just go back a little bit about why timeline is important in illnesses and why you need to be specific, there are particular phrases you can use, such as when were you last completely well. That can kind of tell you when a problem started. And then you need to work out how things progressed. And the next slide will again go into this a bit more detail, but you can ask things like, did it get slowly worse or better? Or did it stay the same or have sudden deteriorations? This gives you an idea as to whether this is a relapsing remitting illness, whether this is a slowly progressive chronic illness, or whether this is a sudden onset attack. Now, you can also ask things like, how long did the problem last for, or how long did each attack last for, and all of these things give you more information about each attack. And then frequency is also useful. It tells you about how aggressive the disease process is and how much we should be worried. This is a diagram of how certain pathological processes differ. So in the front here you have these red bars, and this describes a relapsing remitting illness. So you have an increase in disability, which then suddenly gets better and all the way back to normal, and then they get worse again, and they stay bad for quite some time, but then they get back to normal again. So this is, in the front here in the red, a kind of relapsing remitting illness. This is what something like multiple sclerosis will behave like over time. The black line in the background here is a slowly progressive chronic sort of disorder, and this is kind of what something like dementia might present like. And similarly in the grey background here we have this slow deterioration, slow until things get bad quite quickly. This again, some forms of dementia can present like this, but also things like motor neuron disease can burn along for a little while and be well tolerated until someone really can't cope anymore. So, as you can see, different timelines and different tempos give you an idea of what the pathological process could be. So that's kind of about the presenting complaint and the history of the presenting complaint. And then the rest of the neurological history is quite the same. So you still need to take the medication history, the history of allergies, the family history, their own past medical history, and the social history, including smoking, alcohol, recreational drugs, and recent foreign travel. And then obviously, as with all history taking, we move on to the review of systems. And the review of systems that I've put down here are quite specific to neurology, and for good reason. So this is very important to do at the end of your history taking to make sure that you don't miss any important symptoms, even if the patient doesn't generally volunteer them. Sometimes, for example, a patient may not think that, a change in their mood is important to tell you about, or that they might be embarrassed to tell you that they are having accidents when passing urine. Regardless of this, it's very important, obviously, for you to know that in order to make your diagnosis as precise as possible. Now, here's a list of the things, and I won't go through them, but it's useful for you guys to have a copy of this and to start just mentally noting down in your head what kind of things you want to be asking about. I won't spend too long on that because we should really move on to examination. So first of all, I'm going to talk about the cranial nerve examination, and then we'll move on to the peripheral nerve examination, and I'll highlight the important parts as we go through. Now, we're going to move through the cranial nerve examination in the order of the cranial nerves. So first off, the olfactory nerve. In general clinical practice, all you're really going to have to do is ask them if they've noticed a recent change in their sense of smell or taste, because your sense of taste is about 80% made up of your sense of smell. So often they'll notice a change in their taste first rather than their smell, but often that's all you need to do. There are obviously some objective tests that you can do, like use coffee or perfume, and there are more formal testing kits that can be used, but they're difficult to get hold of, and often it's a tricky art rather than a science. Okay, so that's the olfactory nerve. So we'll move on to optic nerves 2 and 3, and these are the kind of domains that we need to be testing or thinking about when trying to examine. So visual acuity, that is to do with the sharpness of vision, and this is what the Snellen chart here is generally used to assess. Often we try and work out visual acuity of either eye, so they need to do it with one eye shut and then move on to the other eye and repeat it again. Then we have colour vision, and that's what this area here is for. This is a Ishihara colour plate. Often you flick through about 17 of these and work out whether the patient can see all of the numbers as they should be able to see them, or whether they're missing some, and there are some conditions that predominantly affect colour vision rather than others. Visual fields, I think we're going to cover a little bit more in the visual pathways lecture, so I won't spend too much time on it here, but is a very important part, especially from a neurological perspective, and I'll go into a bit more detail in that later. Fundoscopy, this is something that really only comes with practice, and you require an ophthalmoscope for. From a neurological perspective, we're generally more concerned about the appearance of the optic disc. And again, I'll try and touch on that a bit more in my lecture about visual pathways. Pupils, now that I am going to spend a bit more time on here. There are really three main things you want to be assessing the pupils for. The first is reaction to light. Are the pupils constricting in reaction to light, and are they doing that simultaneously across both sides? Accommodation, now this is a part of physiology where the eye constricts or dilates depending on whether you're looking near or far, and that's something to be checked also. And then there's this swinging light test, which the video on the next page will I think it explains it very clearly, so I'll just let that play for now.
Hi, today we're looking at relative afferent pupil defects, or RAPD. This is also sometimes referred to as Marcus Gunn pupil. First, we compare its clinical appearance with that of normal pupils, and also that of a complete afferent pupil defect. To avoid pupil constriction whilst accommodating, ask the patient to fix on a distant object throughout your examination. Look for equal pupil sizes and check again with the lights off. Anisocoria is not a feature of an afferent defect. Now check for a reaction to light in each eye, again with the lights off. Here, the normal pupils constrict briskly, then relax a little. They dilate again after the light is removed. Now swing the light from eye to eye, quickly, but pausing on each eye for around 2 seconds. In the normal patient, the pupils will constrict, then relax a little each time the light is swung to them. Now a patient with a relative afferent defect. The pupils will be equal in size in both light and dark. Both pupils will react to light, although sometimes a slow response is noted when light is shone on the affected side. With the swinging light test, the RAPD now becomes obvious. On the affected side, both pupils dilate when the light is swung across. Here, the left side is affected. You will miss an RAPD if you do not do the swinging light test, as it is only by comparing the relative strength of the signals reaching the brain from the eyes that the abnormality is detected. Finally, with a complete afferent pupil defect, there is no pupil reaction to light shone on the affected side. Due to crossing of nerve fibres at the optic chiasm, an RAPD localises pathology to the visual pathway before the chiasm, that is, the optic nerve or retina. Some examples of pathologies causing RAPD are large retinal detachment, central retinal artery or ischemic central retinal vein occlusion, optic nerve ischemia, optic neuritis, optic nerve compression, or asymmetric glaucoma. It should be noted that an RAPD is not caused by either cataract or vitreous hemorrhage, and when associated with amblyopia, it is usually mild. Therefore, a definite RAPD in these cases should prompt to look for another cause of visual loss. To criticise, comment or share your knowledge.
Wonderful. So, hopefully that's fairly clear. If not, obviously, please ask questions to the person supervising at the end. Wonderful. So just to complete and carry on with the cranial nerve examination, we have eye movements, of course. This tests cranial nerves 3, 4 and 6. And the easiest way to do this is what we call the H test, is to get your finger and move it around in the air and ask them to follow it whilst keeping their head still. This explains what happens with the left eye and which muscles are involved in which aspects of movement. And for the right eye, this would be the mirror image. To move on, we have the trigeminal nerve. So this is the nerve that's mainly involved with sensation to the face, but has a few other functions as well. On the left here, we have a diagram that illustrates that the trigeminal nerve splits into 3. So tri meaning 3 and geminal meaning twins. It's 3 twins, and how those three, each of those 3 branches goes to innervate the ophthalmic zone, which is in green, the maxillary zone in pink, and the mandibular zone in purple. You test each of those separately, just with sort of light touch or pinprick, just like you would any other sensation. And the other function is that the trigeminal nerve gives off some motor fibres to the muscles of mastication. That's the muscles involved in chewing. And you ask the patient to just grit their teeth and feel for the tension in the masseter muscles. And the last function that you test when testing the trigeminal nerve is the corneal reflex. The trigeminal nerve is the afferent part of the corneal reflex, and you test this with a cotton ball into the sclera of the eye without the patient being able to see. Very good. So, to move on swiftly, we have the facial nerve. This is obviously the nerve that controls the muscles of facial movement. And you test these by, I've only illustrated here one of the facial movements, which is shutting your eyes tight. The other aspects of facial movements involve furrowing your eyebrows, so that's raising your eyebrows into the air. The others is to puff your cheeks or smile. And you can test all of those things and just make sure that they have equal and symmetrical strength. The thing being done here on the left is a jaw jerk reflex. Now this, I'm not going to go into too much detail on jaw jerk reflex for now. I think the main thing is to focus on the muscles of facial movement. The next nerve is the 8th cranial nerve, which is the vestibular cochlea. Now, often this is tested by just making sure that hearing is symmetrical on both sides. You can start with the question of have you noticed any change in your hearing, and then objectively test that by whispering a number in the patient's ear whilst covering the other ear and doing the same on both sides to make sure they can hear. Here we have Weber's and Rinne's test, which is a little bit difficult to explain over a kind of audio narrative in this way, but hopefully this diagram is fairly clear on how to examine that. If not, the person supervising this audio lecture can hopefully answer a few more questions about Weber's and Rinne's test, if you have any. Now, this is the testing for the 9th and the 10th cranial nerves. Now, the easiest way to do this clinically and cheaply is to test for a cough. You just ask them to cough, and if you can hear them develop a normal cough rather than a weak one, you can generally say that both of these nerves are quite normal. The other way is to look in the back of the throat and ask them to say "ah." Now, when we all say "ah," our uvula should go up perfectly centrally, and if for any reason when they say "ah," both arches at the back of in the soft palate don't rise symmetrically, that would mean that one side is weaker than the other and could help you work out that that's where the problem is. Sometimes you would always also like to test this by testing the gag reflex. Now, in terms of the gag reflex, the glossopharyngeal nerve is the afferent aspect of the gag reflex, and the vagus nerve is the efferent aspect of the gag reflex. So you can try and work out which of those is involved if they lack the gag reflex. For that, you need a cotton swab, and you need to touch at the back of the soft palate and to see whether the arch goes up in response. These are the last few nerves. So the spinal accessory nerve involved in the sternocleidomastoid muscle, which is being tested here, as well as the shoulder shrug muscles here. Wonderful. And then the last of the cranial nerves, which is the hypoglossal. So for this, you just ask the patient to stick their tongue out straight. Often if they can't stick their tongue out straight, that gives you the answer straight away. And you also sometimes can check for power against each cheek. So you ask them to press their tongue against their cheek, and you press against it to see if they can resist you. Sometimes looking for asymmetry in terms of wasting and fasciculations can also give you the answer. Very good. So let's move on to the peripheral nervous system. This is kind of the mnemonic, I guess, we all use in our heads to remember how to examine the nervous system. So these are the domains you will check in each limb. So inspection, tone, power, reflexes, sensation, and coordination. I'm going to go through these in turn, but before we do that, there's just a sort of general rule of thumb that we use when examining the peripheral nervous system. Now, essentially what you're trying to do is work out whether what you're seeing here when you examine a limb that might be abnormal, whether the abnormalities match up with this being an upper motor neuron problem, that's what UMN means, or whether this is a lower motor neuron problem, that's what LMN means. Now, when we say upper motor neuron, what we mean is anything from the motor cortex down through the corona radiata and into the internal capsule, through the brainstem and down all the way to the level of the anterior horn. Now, if there's some sort of lesion affecting anywhere down that area, they will have this set of clinical signs that you can pick up on your examination. And if the lesion that you're concerned about is distal to the anterior horn, so that will include the nerve roots, anywhere in the plexus, anywhere in the peripheral nerve, then these are the signs that you'll pick up on your clinical examination. I'm trying to move through them and make sure that you guys have some sort of idea of what all these words mean and what they look like if you were to ever see them in clinical practice, which you almost certainly will. Okay, this is quite important to get a handle on and become very, very comfortable with. This is essentially what we look for in the peripheral nerve exam, all right? So, to move on, here on inspection, there's a video happening here which you can have a look at, and as you can see, these small flickers of movement happening in the patient's leg. These are what we call fasciculations, and they denote a problem with the lower motor neuron. As you can see, these flickers here happening just below the ankle. All those flickers are abnormal. And the other thing we look for is wasting. Here we can see quite significant wasting of the first dorsal interosseous muscle, as well as wasting of the thenar eminence. It's not quite as bulging as it should be. And these are things that both denote a lower motor neuron lesion. Okay. So to move on, so that's inspection, and they're the main things we look for in inspection really, as well as things like scars and atrophy. Here is someone examining for clonus. You see how there are this rhythmic oscillatory movement of the ankle, and you see that it was tested by sharply jerking up the foot. This is called sustained clonus. This in an adult is always abnormal, and you can see here that there's more than 10 beats, which is what we define as sustained clonus. Up to around 5 beats of clonus could be normal, but anything more than 5 we generally think of as being abnormal, and it denotes an upper motor neuron lesion, and that's something we look for to give us a clue on what's going on. Okay, so that's inspection done, tone done, and clonus, which comes within the confines of tone. And now power. Now this is difficult to memorise and really only learnt by doing, but here's a sort of a quick whistle-stop tour of what happens. You need to examine each muscle group in turn, and the screening of the upper limb is denoted here, so shoulder abduction, elbow flexion and extension, wrist flexion and extension, finger flexion and extension, and thumb abduction. And the lower limb, there's a few less movements, so just hip extension and hip flexion, that's missing there, knee flexion and extension, ankle dorsiflexion, ankle plantar flexion, and great toe extension. And we measure them in this MRC grading score, which is denoted by is a sort of 0 out of 5 power, which is a complete paralysis, all the way up to 5 out of 5 power, which is normal. As I say, this is a little bit tricky to explain just over an audio lecture, and really you need to do it in real life with a doctor that knows what they're doing, so that you can learn it properly. I'm going to move on from power. We're going to talk about reflexes. Again, I've got a video to show this part, which might be a bit easier to understand.
Examination of reflexes. Ensure hands are washed thoroughly to avoid cross-infection. Introduce yourself and confirm the patient's name and date of birth. Explain the examination and obtain consent. Ensure the patient is relaxed and positioned properly. At the biceps, elicit each reflex by striking the tendon in the crease of the elbow, looking at the bicep muscle to see the reflex.
So that flicker there, just after the hit. So you see here, and you see just this contraction just here, and that's what you're looking for.
Approximately 2 fingers with proximal to the wrist joint to elicit the supinator reflex. At the triceps, strike the tendon above the elbow at the back of the arm, while looking at the triceps muscle for the reflex.
You see, after the hit,
Tendon hammer correctly, and that you swing it in a pendulum-like motion to elicit each reflex at all times.
you see, after the hit, there's a contraction of the muscle. That's what you're looking for. That's normal. Just then.
You can test the reflex at the knee while the patient is seated or while supporting the patient's leg if they are supine. Strike the patella tendon just below the patella with the tendon hammer to elicit the reflex. An alternative way to test the ankle reflex is shown here, as the foot is slightly dorsiflexed and the sole of the foot is then struck to elicit the reflex.
As you can see, there's a small kick-out motion of the foot. That's what you're looking for.
Check plantar response. If the patient's toes flex, this is normal. The test is considered positive if the great toe extends and the other toes flex or spread apart. Reinforcing upper limb reflexes.
I'm going to pause there. I think reinforcement is a useful thing to learn about, but I think if you learn about just the reflexes first, and then we can move on to reinforcement, or you can ask questions about reinforcement if necessary. Good. So that's reflexes. We'll move on to sensation. Now, again, I'm going to try and cover this a bit more in our in the sensory sort of physiology and sensory examination lecture, but to quickly run through it just here, there are various modalities of sensation in the peripheral nervous system, and the modalities that we care about are light touch, pinprick or pain sensation, vibration sense, temperature sense, and proprioception. Okay, so light touch is examined with usually cotton wool or most often just with your finger to just check whether they can sense what you're feeling and comparing like for like and comparing for symmetry. The same goes for pinprick. Really, you're looking for symmetry, and you can test this with a neurotip just here. That's what that is, the neurotip with the sharp end. Vibration sense. Now, this we usually match up with proprioception and light touch because they're all carried along the dorsal column in the spinal cord, and we test this with a large tuning fork, a long tuning fork, 256 Hertz, on a bony extremity. So here it's being done on the lateral malleolus, and then you can also use the same tuning fork, which is often colder than the surroundings, just to make sure the patient can sense the difference between cold and hot. And then proprioception is done just by checking that the patient knows whether their finger is up or down as you move it around in the air with their eyes closed. The other way to do this is a Romberg's test, which is to ask the patient to stand up and whilst you're there to make sure they don't fall over, to close their eyes and see whether they can stay standing or whether they sway excessively. Very good. The last part is coordination. Again, this is a little bit difficult to explain over just audio, so there's a video just to explain what we check for in coordination. I'm going to skip over the first aspect just in the interest of time.
Now I'll talk about the evaluation of coordination. There are many tests that can be done to evaluate coordination, and therefore we've chosen a few that should be used in a screening examination. It's important to realize that cerebellar testing and coordination testing are not synonymous. Patients with motor problems, with sensory problems, can have discoordination, although they do not have a lesion of the cerebellum. Therefore, this should be called coordination testing, not cerebellar testing. Let me have you take your index finger and touch my finger, asking the patient to stretch to arm's length and touch my finger in different positions. Now touch your nose, touch my finger, and go back and forth. The patient has a slight intention tremor that's visible at the end of the movement. Now I would do a similar examination on the left side. Also, in the upper limb, we will test the hand coordination by having the patient perform a rapid alternating movement test, slapping his hands back and forth from back to front. Can you do it a little more slowly? And now speed up. Good. I'll have you lie down. In the leg, we'll test coordination by having the patient run his heel up his shin to his knee and back down as accurately as he can. And now the other side. Good.
Excellent. And that's really the main test that required in the upper limb and the lower limb for coordination. Very good. So that sort of brings us to the end of an introduction to history taking examination. Obviously, this is not a complete guide to every single test that you can do in a neurological history examination, but it is a good guide to what's expected of the basic neurological examination. And hopefully today I've gone through how to take a good history, the differences between timing and tempo of symptoms and how that can help you work out the diagnosis. And also we've had a whistle-stop tour through the cranial and peripheral nerves and how to examine them. Thanks very much for listening, and if you have any questions, obviously please direct them to the person supervising, or we'll try and work out a session in which you can ask us the questions. So please do write them down and we can try and respond to you as soon as possible. Thanks.